Hi. And welcome back to Happy Seminar. It's nice to see you all here. We have a really exciting seminar speaker here today. Another one that was recommended by one of you out there. I'll leave that anonymous until we see how he does. So I am pleased to introduce Dr. Tyler Winkelman, who is the co-director of Health, Homelessness, and Criminal Justice Lab at the Hennepin Healthcare Research Institute, and he's also the director of the Research and Evaluation Data Analytics Core and the division director of General Internal Medicine there. And I want to point out that that is a practice across 8 clinics, which include the Hennepin County Jail and the Healthcare for the Homeless site. He is a practicing general internist at Hennepin Healthcare. He went to medical school here at the University of Minnesota and did a Med-Peds residency training here as well. He also has a master's degree from the University of Michigan in health and healthcare research. And as you will learn more, Dr. Winkelman studies issues at the intersection of criminal justice and health, with a particular interest in Medicaid, substance use disorders, and healthcare utilization. So thank you, Dr. Winkelman. And before we get started, I want to give you a present to thank you for coming to give a seminar here. This is our very special seminar speaker. I hope you find the time Bob.
Yeah, it's fun to be here. Thanks for having me. I have been following W Bob on Twitter for a while, and I had no idea this is where it was. So I was able to walk over from my office, which is like very lovely. It's not often I get to just like walk out of my office to do a talk. So you know, if it doesn't go horribly, I'm happy to come back. It was delightful. So yeah, I'm also a relatively informal speaker. So if folks have questions as we go, feel free to yell at me, and happy to take a pause and provide further clarification. So the objectives of this talk are to describe a statewide effort to enhance public health infrastructure through linkage of EHR data, administrative data, describe how our team has organized jail, prison, and homelessness data with an open source common data model, and then I'll give some examples of how we've put the data to use. And as I continue to work with this linked data, now that we have it, I will admit that I think the opportunities for this far surpass what we've currently done. So I will show you what we have done so far, but I think I'd love to think through with you all what are some other opportunities to use this type of a data source. So I'd like to give a little bit of background on, you know, what kind of led to this work. Talk about the development of the Minnesota EHR Consortium, and then I'll spend a fair amount of time really like diving into the weeds on like what are we actually talking about with the data elements in this work. So it's not surprising to any of you that COVID really revealed how insufficient our public health data infrastructure is in the United States. There's been a lot written about the underinvestment in public health infrastructure, and the need to really bolster the data that we have available to inform crises and public health events. And if you take that one step further and you think about data that's guiding policy and practice in the criminal justice and homelessness space, it's even bleaker. So these are articles that have been written by some of my colleagues at University of Colorado, at UNC, and other universities across the country that really are nicely highlight just how remarkably poor our data are, particularly when it's related to vulnerable populations like people experiencing homelessness and incarceration. And then sort of so there's this like public health infrastructure generally, in particular for vulnerable populations. And then the other, like, I think, challenge here of making data systems work and quickly leading to operational and practice changes is how siloed healthcare and public health are in the United States. So I think Kumi and Faye have already seen this slide because I presented it a couple weeks ago. But I really love this graphic that's out of a guideline or a policy piece in one of the family medicine journals. And in the blue is sort of the square of the types of domains that primary care spends a lot of time thinking about. And in green are the domains that public health spends a lot of time thinking about. As you can see, there's a ton of overlap, yet for the most part, primary care and public health agencies are operating independently of one another. And so within this context, we saw that this huge need for improved data quality in public health. We saw a need to really be thinking at the front end about how you integrate data for vulnerable populations and bringing partners from both sectors, public health and healthcare, together. We saw that electronic health record data, so this is data that's being entered during clinical assessments and exams in an emergency department, a hospitalization, or an outpatient visit, really has some interesting advantages as a data source. One, it's timely. So databases that house EHR data are usually being updated on a nightly basis. So this is current real-time data. It's granular, so you can understand, you have address information and more granular demographics that are typically available. And these are established collection methods. So all this data is already coming in. You don't have to send a group of people out to the field to be collecting it. A philosophy that's driven our group, and I think we could spend a lot of time sort of just talking about this one point, but we felt that often, I think in Minnesota in particular, which has some unique data privacy laws, centralization of data has often failed or been particularly slow in the US. But EHR data can relatively easily be aggregated without centralization. And I'll tell you how we've done that with data, individualized data staying behind the firewalls at each of the health systems. And like I mentioned, sort of using this healthcare derived data for more public health purposes really requires collaboration between healthcare and public health. So in March of 2020, we began our journey to develop the Minnesota EHR Consortium, and today it is a collaboration with the 11 largest health systems in Minnesota, the Minnesota Department of Health, and a growing list of public health agencies. And Hennepin County Public Health has been a key partner in both some of the projects we've done with them and also in cultivating relationships with other local public health agencies across the state. And then Minnesota Community Measurement, which is the statewide organization responsible for specific quality reporting that's required by payers, is also a participant in the consortium. And these health systems cover most of the state of Minnesota. There are a few places where data are a little bit more sparse, but I think in our lowest county, we have 40% coverage. And when you sort of think about the percentage of a population that a survey would typically survey, we have fairly broad coverage. This did not happen overnight, but I would say that COVID really sped things along, and we, in some ways, did not want to let a crisis go to waste. So in 2020, we established the work with a core group of health systems that had existing research infrastructure within their health systems and started testing whether we could pool our data collectively to say something about COVID. It turned out we could. And in the fall, at the time when we started, we were sort of like, everyone pull COVID data, like whatever that means to you, and then we'll put it together. And then in the fall, we kind of created our own homegrown common data model where we tried to standardize a little bit how we were pulling COVID information from each of our EHRs. In December of 2020, I was on a call with the state when they said, could this work? We were doing testing work at the time, and they said, can you do vaccines? And I was like, yeah, I don't see why not. I don't come from a technical background. And it turns out that when I said sure, we actually couldn't do it at the time, and it required a major overhaul of our processes. And so by the time I realized that, the governor had been briefed and said, great, we'll report this disparities information in February. And so in 6 to 8 weeks, we had to renegotiate an 11 health system DUA, implement a hashing-based privacy preserving record linkage, which I can talk about, and figure out a way to deduplicate EHR records across the state. And then get all of the COVID vaccine data from the state and link that into EHR data. So that was quite a month, and really set us up though in the long run to do exciting work. In June of 2021, we got approached by the state to say, hey, like we're hearing reports of really low vaccination rates among people experiencing homelessness or incarceration. Could we start doing something with that? And our lab had done work in that space before, and so we were able to add that data into the consortium. And actually that process in January to deduplicate made that process work. And then we received infrastructure funding from the state in 2022 to start building out a true version of a common data model. And I'll talk a little bit more about what that means. So we have a few key principles that drive our work. We have privacy was like items 1, 2, and 3 when we first started our discussions. And the way we chose to address it was through a distributed data model. Again, I'll kind of run through in more detail what that means, but the individualized data sit at the health system. We are not creating a centralized data resource. The collaboration is voluntary. The health department doesn't mandate that anyone do this work. We have a governance board, we have an executive committee, we have a charter, and in the early days of setting this up, we spent a lot of time on how we make decisions, who's at the table, and what is our decision-making process. We've really tried to maintain some adaptability and nimbleness. I think one of the key strengths of this work is that we try to generate data that's not delayed by a couple of years. It's pretty common that with public health data, the data are 2, 3 years old, but you need to make decisions about like this year's budget, and you don't exactly know like what the state of the state is at the time you're making that decision. We've set up a scientific review committee that reviews proposals and manuscripts, and Kumi's probably thinking that process could use a little bit of reworking because it's not the smoothest, but it's this ongoing evolution to try to understand how to systematize some of these processes. And then we have a master DUA that I think is like going to be my crowning achievement of my career across all 11 healthcare systems. So what is included in the data that we have? Obviously, we have EHR data. We've mapped over sort of all of the EHR data. So it includes anything that would go into a record, whether it's an encounter, the clinician's specialty, the diagnoses, the medications, the vitals, the lab values, all that has been mapped over. We use census data at the area level to report on area level income and morality. We get all of the flu and COVID vaccine data from the state, and then we actually currently are also getting almost all of the childhood immunization data and doing work around disparities in childhood immunization. We report on estimates using the CDC's Social Vulnerability Index. And then we link in state homelessness shelter and incarceration data. We have state mortality data, Medicaid enrollment data, and we've been working with a group at the university to also link some of our emergency department encounter data to extreme heat data. And we have some preliminary analyses for that. I don't have them on my slides, but hoping that that data is finalized here in the next couple of months because it's super interesting. All right, so a little bit about how does the data flow? And again, I come at this work really from like a conceptual standpoint, I guess, and then we have teams of analysts at each of the sites that does a lot of the granular work around mapping and building out the technical infrastructure of the databases. So this is a figure that our colleagues at Health Partners put together for a recent talk that I think is slightly oversimplified, but I think tells the story the right way. We get external data that is usually hashed at its source, and I'll tell you a little bit more about hashing in a minute. And then that comes to the university or to Hennepin Healthcare. If it comes to us, we usually have to clean up the data, like the jail data and the homelessness data, before we pass it along to the university. And then in the university's data shelters, where we link all these external records with hash IDs that we receive from the systems, and have a deduplication process where we tell each system sort of who they should report on, which hash ID they should report on, so that we're not counting people more than once. Then we send out that sort of roster of hash IDs to the systems with the R code that has the analysis we want to run, and the analysis is run at each of the systems. And then they send a summary back to a central location for the projects I run. It's Hennepin Healthcare. And then we stitch together a summary of summaries to generate statewide estimates. So there are a lot more steps involved because it's this distributed data model, but it also means that there's no one entity responsible for housing the state's EHR data, which is has lots of risks involved. So this kind of paints a nice simplistic picture. In reality, this is like the real process where there are data sort of like constantly flowing back and forth in various ways to make this all work. And so you can see here though in blue is like this OMOP common data model that exists at each of the sites that really drives most of the work that we do. So I did not know, I'd never heard of hashing before January 2021. Steve Johnson at the Institute for Health Informatics taught me a lot about this. But essentially, what you do is you take certain data elements. So in this case, first name, last name, date of birth, phone number, you hash it together, and you create you run it through an algorithm to create a string of characters that then represent someone. And unless there's sort of in addition to the algorithm, there's like a code you have to have that you put into the algorithm. So you sort of have to have the exact algorithm, you have to have the exact code to be able to, with some crazy machine, be able to de-identify it. So for practical intents and purposes, it's considered de-identified. And then we're able to pass these de-identified files back and forth and link them to each other without having to send identifiable information across systems. This is the population that we have after we deduplicate. So 5.6 million individuals are represented in the data. In 2023, the census said about 5.7 million people lived in Minnesota. The population distribution is like slightly different than the census in that we've identified more older people who we think live in Minnesota and fewer young people than what the census says. But the total populations are pretty similar. the population in the EHR data, it also is like fairly substantially less white than what the census reports. And so we had historically used census data as our denominators, but we had to stop and build our own denominators because for our Native American population in particular, our estimates just weren't remotely realistic. And in Hennepin County, for example, there were like twice as many Native American individuals that were showing up in electronic health record data compared to what like the census said lived in Hennepin County. So this next I'll talk a little bit about like what is OMOP. So again, this is a common data model that now it exists both at the university as well as the 10 other health systems, big health systems across the state. It is a common language, so it doesn't matter how a health system stores their health information. It is all mapped over to the same language. The language of OMOP is concept IDs. So what that means is that diagnosis codes, for example, can be stored in a variety of ways. They can be stored in SNOMED codes. They can be stored as ICD codes. OMOP doesn't care. Regardless of how you're storing your diagnosis code, we'll map it over to its corresponding concept ID. And then this is true of encounter types. It's true of labs, of medications and so forth, so that everything is stored using the same mapping process and concept IDs so that we can, as best as possible, compare apples to apples. When we were deciding on what common data model to implement, we had a common data model work group, which is quite the party, and went through a variety of different options. And really what made us land on OMOP is it's open source. So there's no cost to the health system just to get information about the data standards and the mapping processes. It's international, so there are sites across the entire world that use OMOP. There are NIH and CDC increasingly are using OMOP as well. The big sort of COVID registry that NIH built during the pandemic was built in OMOP. There was some local experience at the university and a couple of the other health systems that really allowed us to establish like a technical assistance for the consortium that could help other sites get onboarded. And we've felt that it's important that we don't just set up the database for a site and then as like a consultant, but that we help build capacity within each of the systems, because even though most of the sites have Epic as their electronic health record, Epic is built differently, and there are just these like bizarre nuances across health systems, and so it's really helpful to have that local expertise. A few of the health systems did decide to sort of contract out the build and then hand it over to an analyst, and that's been a pretty rough transition, and they've had to sort of take a step back, and their analysts has had to spend a lot of time like relearning the database. And then this is the tool that we use to sort of identify different concept IDs, and there's all concept IDs for all sorts of things. So for example, like there are concept IDs that are already in OMOP around jail. And so we are building on these sort of established concept IDs to create sort of a Minnesota version of OMOP that can house some social determinant of health data. So we get in a variety of administrative data that's not exactly what OMOP was built to do. And so the OMOP purists don't love that we're doing this, but it is been really helpful for us. And now we have we're applying for grants to try to do this in more places across the country. So the two data sources I want to talk about are the Minnesota Department of Corrections data. In Minnesota, we have a centralized resource that includes all county jail and state prison stays. And it is an encounter level file that sort of monitors each episode of incarceration. And then sometimes you do have to, it gets tricky it's pretty common for people to go to like 2 or 3 different jails and then to a prison, and you have to spend a fair amount of time sort of like stitching together the complete incarceration episode, because the records start with each different facility. And then the homelessness data comes from HMIS. Each state has this as a mandated reporting tool. It captures homelessness service use, and that would include shelters and supportive housing and street outreach. It included like the hotels that were used for housing during COVID-19. And then again, it's always encounter based. So like the shelters, one night is one encounter. So if you stay in a shelter for 20 days, you'll have 20 different lines for each of those nights. In OMOP, there is a table called the observation table. That is where like anything that doesn't have a nice tidy home lives. So it's a gigantic table. We created a copy of that to store this admin data. And what we found is that when we match in the homelessness and incarceration data to the EHR data, we get a match for about 75% of folks that are in the jail, prison, and homelessness data systems. Like I mentioned, Hennepin claims the data and creates these episodes and so forth, and then we send it over to the university to merge into the central process. And then this is, essentially how we end up storing it. So we sort of take this super messy administrative file, and then we assign it the OMOP concept IDs, and we input the data that we receive in the administrative files into its like appropriate column in the OMOP database. And this allows us to identify people who have experienced homelessness or incarceration. And then also it provides dates. So if you want to understand, say like and I'll show you in a bit, like emergency department visits after an episode of incarceration, the dates allow you to do analyses like that. All right, so I'm gonna fly through some of the COVID stuff so I can get to our newer projects, but I haven't been able to totally drop this from the presentation yet, because it was like such a passion project at the time, and it was the first time we were able to stitch this data together. But early on, like I mentioned, we were asked to start reporting on COVID vaccines among people experiencing homelessness or incarceration in Minnesota. We were, I think, the only state to be able to do this at a statewide level. And this was a sort of ultimate publication in health affairs, but prior to this, we were working really closely with the state and counties on identifying areas where vaccination was low, and this really helped to drive more resources to the teams of the state that were trying to get these groups vaccinated. And I think that's been one of the very rewarding things of this group, is we've been designing the analyses directly with stakeholders who need the data, so that as soon as it's ready, they're making decisions about funding and priorities to drive change, and that happens well before the final manuscript is accepted. But here you can see, we showed that the vaccination rates for people experiencing homelessness or jail incarceration were substantially lower than that early on in the booster era. The booster rates were quite low as well. We also can look at viral illness in these populations as well. So here we've mapped COVID and flu positivity among people who've been in jail in the past year and those who haven't, or people with recent homelessness and those who haven't. One of our active projects right now is around substance use related emergency department visits in Hennepin County. And the goal of this with Hennepin County has an opioid coordinator. Her name's Julie Bauk. And she wanted more timely data. She was relying on mortality data as kind of the sole source, which if you're trying to intervene more proximally, isn't all that helpful and often was quite delayed. So we work with consortium sites that have at least one hospital in Hennepin County, and then have been submitting data on a monthly basis. And this has been typically we have built our own dashboards. This is we were able to bring on Hennepin County in our DOA as well, and then send them data that they use to build the dashboard themselves. So this shows at a high level annual ED visits by different substances. And for many substances, in particular opioids and psychostimulants, and the combination of the two, you see pretty substantial increases year over year. One of the newer ways that we've been trying to inform different interventions is to look at what's happening after people leave jail stays. I helped start the opioid treatment program at the Hennepin County Jail. And just to kind of give you a sense of the scale, there's about 800 people at the Hennepin County Jail on any given day, like about 70 admissions, 70 discharges a day or so. About 20% of the jail receives treatment for opioid use disorder on any given day, so approximately 120 people per day, and then 3,000 to 4,000 people a year receive opioid treatment. Some continue when they leave, some don't. Some are connected to services, many are not still. What we wanted to know was sort of when on the figure on the left shows among sort of all ED visits among people, say who like haven't been incarcerated, about 2% of those visits are related to opioid use. For folks who've been recently incarcerated in the last 3 months, about 15% of their ED visits are related to opioid use. And then when you look at sort of the universe of all opioid-related emergency department visits, about 25% of those ED visits are occurring after someone is leaving jail. And I think I'm biased because this is my area of focus, but I think that we often talk about these big systemic issues of opioid-related ED visits. But what we're showing is that like you can intervene in potentially relatively few areas and potentially like decrease that number by a quarter, which would make a huge difference. And then the final project that I wanted to highlight is our Health Trends Across Communities project, which is the biggest project we've done to date. And it is a sort of a collaboration of collaborations across health systems, local public health, and health plans. And the sort of leadership team is the EHR Consortium, the Center for Community Health, which is a group of metro operational leaders within health systems, health plans, and local public health agencies. And the goal that we set out to achieve was to provide accessible, timely, and detailed reports using EHR data that local public health agencies could use in their community health assessments to guide priorities and funding. So these are the groups that I mentioned, a consortium of consortium. And yeah, our goals was to build a comprehensive public health data infrastructure, and with the aim was to drive community health assessments and to strengthen community capacity. So we wanted something that was publicly available, that wasn't just available to large organizations, but that any community-based organization who's applying for a grant or trying to understand the need in their neighborhood could use this to inform their work. So these are the ultimately the indicators that we were able to include in version 1.0 of our dashboard. It includes substance use variables, mental health variables, chronic conditions. We have some maternal health variables, and then like I mentioned, we have climate change analyses, and we also have gun violence indicators as well. And then as we were building out some of these, we were also really working on stakeholder engagement. And when we initially set out to do this, I was thinking that we would start talking to patients right away and folks impacted by these conditions. And what we quickly learned is that like these local public health agencies and health systems and payers had never really worked together in this way before. And so like we kind of had to reframe how we thought about stakeholder engagement to really understand like what each of these partners wanted out of this. How could we work together collaboratively, and spend a lot of time trying to understand like the hopes and needs of the users of the data, and wanting to inform the work that these public health professionals were trying to do. That has gone well, and I think we absolutely have interest in doing more sort of patient-facing engagement work with this as well, and it's something that we're hoping to build out sort of with our next round of funding that started a couple months ago. So I think what I'll do is just switch over to the dashboard and show a little bit about what it can do, because I think that's a good jumping off point for questions and comments. And then before I do that, I'll just maybe say there's other things that we're working on right now. We're implementing natural language processing to be able to search the text of notes, and hoping that should be kind of ready by late spring of next year. We've had some like preliminary work in that space, and it's been very promising. We are continuing to try to understand like how best to create denominators with EHR data, which is fascinating, and there's some members in the group would love to pick your brain. We're adding more therapeutics. We're adding climate change indicators. We've developed an implementation for that is operational leaders at the state to say like, okay, we have this data, like how could we collectively make a clinical change across our systems to impact some of these statewide estimates that we're finding. And then I'm particularly interested in how can we use these data for policy evaluations. The big sort of policy change that I've been involved with is around Medicaid's 1115 reentry waiver, which is a change to our state Medicaid plan that would allow us to use Medicaid during periods of incarceration. So right now there's federal exclusion that doesn't allow you to bill Medicaid during incarceration. That is supposed to get turned on in January of 2026. And most states don't have the ability to understand what's happening after incarceration because these data aren't linked together. And so I'm really interested in how to use the data source we've built to evaluate some of these big policies that are being implemented across the state. All right. So let me share the dashboard. Right. So this is a dashboard. It's available publicly. Feel free to tool around on it. One of the questions I almost always get asked is, are there public use files? We can provide. So if you're at the university, you have access to the underlying data because of the DUA. If other agencies that request public use files, we will kind of do them as a one-off. But our goal is by early next year to have some type of public use file that's compliant with our privacy regulations, which is really, having started this work in 2020, like a huge change for our group. There were, when we started, there was a lot of fear across the health systems about doing anything public. And so sort of having a public facing dashboard, starting to post public use files is a really big, I think, testament to the trust that's been built across this group over the last few years. So here's the demographics. This is that 5.6 million number I had mentioned. These are the demographics of the population across the state. This is where you can look at adjusted and unadjusted estimates of different conditions by race, ethnicity, gender, and age. And so you can go through here and get different estimates of conditions across the state. There's a geography tab where you can map these at the census tract level. You can limit it to different categories of SVI. You can also select a region, a county, or a city. But let's just select Hennepin County. We're trying to work on the auto zoom. It's like the biggest pain in the butt. It's something we talk about constantly. So you should rip on it too, because it's annoying. And then when you select a region, the figures on the right will update. So this would be the estimates by race, ethnicity in Hennepin County, by gender, and by age. And then we have this special populations tab, where this will give you the demographics of these different populations. And you can, in clicking through, quickly see the different racial disparities that exist within each of these populations. And then you are able to compare these different health conditions by your category of interest. So if you want to know sort of racial ethnic disparities in opioid use among people experiencing homelessness, you can click here and get those disparities. So yeah, please take a look. Let us know if you think anything's particularly interesting. We're slowly starting to work on manuscripts from some of this, but there's lots here and plenty to write about. We just closed our survey of what our stakeholders for sort of additional elements that they'd like to see in the next round. We will be adding more information around pregnancy, around pediatric well child visits, and then there's sort of a long list of other priorities that we're going to make our way through. We are also doing what we call deep dives. So we have like the prevalence of diabetes, and then we have a team at Health Partners that's looking at across the state, what are different rates of diabetes control, what medications are people taking, who's getting the recommended screenings, a variety of other in-depth questions. So thanks for your attention. You've been a great audience, and I think at this point, happy to take any questions or comments folks have.
So thank you so much. Questions?
Thank you. That was super interesting and also amazing data. I know you guys are working on like sort of continually expanding this resource. So I'm curious to hear, in a dream world, what administrative data, what other linkages would you do? And then which of those do you think might actually be feasible?
Yeah. One of the, so there's a couple things that come to mind. One, we're working with a group at Mayo. They have this index called the Houses Index. And it is the, each address in the state that is associated with like a property value. And they've shown that sort of using like the address of some property value is a better proxy for income than a lot of the proxies that we have. So that's one thing that we're actively working on. I think that there's a real opportunity to look at SNAP benefits as well, and I think that is actually potentially feasible. The other area that I'm like just starting to try to wrap my head around is possibilities. There are different health information exchanges in the state. Minnesota's like behind in this like health information exchange, but the idea of them is to better send data for clinical purposes across the state. So I'm mentoring a clinician at Hennepin right now who has worked with the HIE and developed a way to, from the exam room, directly send a referral to WIC for services. And then WIC sends the sort of what they did with the referral back to the clinician. And so it, like from a research perspective, that like, creates these social service flags in the EHR. And I think the more that the different state agencies start to use the HIE technology to be sending data in more real time and getting away from paper and faxes, that this starts to like create a lot of information about like the different services that folks are engaged in. I just was on a panel yesterday with folks from Massachusetts and Wisconsin that have those states, and they're set up a little bit differently. Wisconsin's is housed at the University of Wisconsin, and then Massachusetts, their integrated data is housed at the state. They have, I think like in Massachusetts, they have like 25 integrated data sets. And states have figured out how to do it. I think we're all trying to figure out collectively in collaboration with the state is like, how do we do that? It works to both sort of build that infrastructure within state government and out of state government. And those are a lot of the conversations we're having right now is like, kind of, as far as I can tell and talking with folks around the country, you kind of go with whatever path works.
Thanks, Tyler. That's so cool. Data like health science researchers are always like longingly looking at like Northern Europe or like we had a speaker from Japan and they just, you know, these are places where everyone has one number and that one number is like to like literally everything. This is like the closest I feel like you can get in the US. Did you talk about what, maybe it was partly COVID, but what did it take on like an interpersonal level to get all these people to the table and being willing to participate? I guess my assumption is that it's easier for people to say no because there's no penalty for backing out of a consortium like this. Whereas the reward for participating is like more DUAs, more deadlines, more work. And feels like you navigated a lot of that successfully. Could you just talk about that personal experience?
Yeah. So I would say, and I should have shown this slide, like this, I get to sort of be the spokesperson for this collaboration, but there's 50 to 100 people engaged in the work who are all invested and spend a lot of their time working on this project. And I think we're up, like with all of the projects, I think it funds 20 full FTE across the state, spread out across lots of different people. So it has just, I do think we started with like a group of people who were all really invested. I also think it is really helpful to organize, at least initially, but I think long-term around issues that like you can really see the impact and that you feel like it actually means something. So like we like really did inform our state's response to COVID. We built this data resource because we thought it would help public health agencies do their community health needs assessments, set priorities, and change like the types of surveys they were doing so that they could focus on maybe other things they cared about now that they didn't have to try to estimate chronic conditions in their area. And that's exactly what's been happening. And like we have had local public health agencies say that they've like already, I mean, this was released in April, like dramatically changed their workflows because of the data that they're getting. And are really engaged with our group. So I think like having a strong purpose is important. And then I also think in a lot of these spaces when we've tried to get data out of healthcare systems, it's been like, well, you're just like sending us data, like just send it to us, you know, and there's no funding or acknowledgement of like the work that goes into it. And it's also hard when you're just sending it, you don't know what happens to it. And I think it's been really helpful to like acknowledge that like cleaning up data out of the EHR and putting it into some standardized format takes a lot of time. And the analysts who are doing that work are just as excited about the outcomes as like the PIs are. And so it has helped make the work that can be like somewhat monotonous at times, like meaningful. And we just pay people for the time that it takes to do it. And I think these, yeah, I think I've seen like our health system even just react of like, if there's a data mandate, like most, especially safety net health systems are so strapped for cash that like any little additional request is like almost gonna tip you over the edge. And they like often they like actually the motivation is there. It just like literally can't do it. And so being able to bring resources in to say, hey, like we'll pay you to do this work, meaningful work, and we want it done is I think then like it sounds super simple, but like pay people when they do work has been really important. And that like just mandating and saying, hey, health systems send us all this data without like thinking about all that has to happen in order to do that has been.
You may have mentioned this and I apologize if I missed it, but where is the funding for this coming from?
Yeah, so we have a couple of different sources. We have funding directly from the state through some of their like public health innovation grants that they have. We have some funding directly from Hennepin County for the substance use work that we're doing. We have contracted directly with CDC for some of the work, and then we have some grants that are NIH as well. So we've kind of pieced together funding from a variety of different sources. It was interesting. I've always thought like getting a legislative proposal would be like the holy grail. And I still think that actually, but I was in Wisconsin, as I was listening to their speaker from Wisconsin talk about how they've developed this integrated data source in Wisconsin. They've actively avoided legislative proposals to sort of stay out of political wins and have really focused on only the NIH CDC Foundation type of funding. So I think we're a slightly different political context than Wisconsin. So I think the calculus is a bit different, but I'm hoping that in the long run there are a couple of different potential ways to fund sort of ongoing infrastructure funding, not just through legislation that we're also pursuing, because I think like for any type of research project, like it's helpful when you have some baseline funding. But right now we've been able to keep it rolling through a variety of different funding mechanisms.
I have a second question.
Okay. There were some hands that were up before that no longer are going up anymore. There was Andy and Nancy before. Do you guys have questions?
I cede my time to Susan.
Susan will have the last question. Go for it, Susan.
Sorry. Well, I was curious, you mentioned the sort of risk aversion and the labor issues within the health systems, but I'm also curious about the state level because in various conversations I've had with, about data linkage, like in particular, Minnesota Department of Health is particularly
Yeah.
resistant to these sorts of things. So I'm curious what your relationship with them is like and what that looks like getting data from them.
Yeah, so MDH is has a seat on our governance board and in our executive committee. And I'm in meetings with them like multiple times a week. They also, like for our Health Trends Across Communities project, they have a couple folks on our advisory committee. And then we also meet with them sort of on a bi-weekly basis, just on like overall grant progress. So I guess I would say like, we're engaged with a variety of folks across the health department and it has been like a really, and I'm not trying to like say this to be cheesy, like it's been a really great collaboration and it has felt like a collaboration. And I think everyone's just trying to build something useful. I do think there are different there are some different like data needs for public health than maybe there are, or maybe I'd say there are additional public health needs regarding data that like the consortium needs. So the consortium is not designed to be like a tool for reaching out directly to people who have an infectious disease, for example. But I think so I think there are still like data modernization issues that need to be addressed within like the health department. And there are ways that like linkage within the health department could be helpful in doing that type of work. I think that what the consortium brings to the health department is like data are data. It really matters what you do with them. And historically, when data go to a health department, there's, a relatively small group of epidemiologists that have access to that data. And I think what we've tried to do in a sense is like democratize that data. And we have, dozens and dozens of really bright folks that now can ask questions. And I think that what it can do is not replace what epidemiologists at the state does, but ideally brings like this whole group of people into the fold to improve public health that like previously might have just said like, well, I don't have access to that data, so I can't do anything about it. And that's, I think, where the consortium can honestly be like the most helpful is in sort of the people and the expertise that we bring into the fold to try to improve community health.
Well, we are at the top of the hour. Thank you so much, Tyler. That was fantastic. I think we could stay here and ask you questions all afternoon. I know I could. We have, I believe it starts at 11:10. The PhD seminar is in this room. And I think Tyler is able to stick around for a little bit. So if there were some PhD students that had questions that we couldn't get to, you'll have some more time. And I apologize, Nancy, Andy, and Russell, I saw your hand go up at the end. That I wasn't able to get to you, but we've got 10 minutes before the PhD seminar and we want to make sure we can turn things around. So thank you so much. That was fantastic.